There are two kinds of light. The glow that illuminates may also cause glare that obscures. Imagine you have just performed a successful, uncomplicated, uneven full cataract surgery and given your patient vision of 6 by 6 and surgery looks beautiful and you are ready to be congratulated. But instead when your patient says, "Doc, I hate these unwanted images that you have given me. This is not what you wanted to hear." So what is dysphotopsia? Dysphotopsia is undesired optical images associated with otherwise uncomplicated IOL surgery, and patients are incredibly unhappy and they move from one ophthalmologist chamber to others, and when they are told your surgery is perfect and there is nothing wrong, this makes the patients more angry. So although this term is gaining acceptance, it's a misnomer. Why? Because photopsias are visual perception that arise in the absence of light stimuli, but visual disturbance of dysphotopsia do not occur in the absence of light stimuli. In the literature, terms such as photopsia, entoptic and photic phenomena have been used, and the term dysphotopsia was used for the first time in June 2000 by James Thurber. So it's a Church's proverbial riddle wrapped in a mystery inside an enigma. It's an enigma of cause, prevention and treatment. And when the surgeons tell their patient that it will go away in time, it does not always turn out to be true. Some of these patients are so upset that they have filed lawsuits against ophthalmologists, and now there is a website for patients who are miserable because of these symptoms. So there are two major categories. I'll talk mainly about those arising from the IOL edge. Edge reflections are called positive dysphotopsia, and edge scotomas are called negative dysphotopsias. We wanted some desirable traits in our foldable lenses, which had led to undesirable optical phenomena. Which we wanted a thin lens to go through a small incision, it acts like a mirror. We wanted square edge to decrease PCO, it caused internal reflections. Hydrophobic IOLs were supposed to cause less PCOs, but they cause more photopsias compared to hydrophilic because of low anterior curvature and high refractive index. Truncation, bitruncation, all cause mirror-like effects. So negative dysphotopsia was reported first time in 2000, who likened this to horse blinders. It is commonest type, less understood, more debilitating than positive dysphotopsia, and unfortunately or fortunately, it is associated only with perfect surgery, perfect surgeon, good lenses. It does not occur with otherwise. It is a sickle-shaped dark shadow crescent that gives the impression of a shade over the temporal periphery. So why does it occur? Simplistic explanation is temporal rays of light, when they come and strike the nasal edge of lens, they are reflected back. Since there are no light rays to be refracted, so it causes a shadow in the nasal periphery. So it is manifested by a dark crescent shadow, and Holliday has done a lot of work and he found that there are type 1, type 2 and type 3 shadow. This is classified as type 2 shadows. So one is the light which is coming and grazing the anterior surface of lens, that is the anterior edge of this dark shadow, and the light which is refracted from the inferior edge and then the posterior surface. There is a crescent or scotoma between these two lines, and this causes this causes negative shadow. So why sharp edge? So what is the difference between sharp and round edge? You find that in round edge, the light rays which are refracted from the inferior edge and the posterior surface, they bleed into this area marked 4. Whereas from the sharp edge, you find that the light rays from the posterior edge is refracted much more than the light rays which are refracted from the inferior edge. So this black shadow which is marked at 4 causes a shadow. So these are the experimental models where they have found the light rays coming from various angles in the temporal field of vision, and they found that a particular angle between the 90 degree and 60 degree, this is the angle where the one light rays is grazing the anterior surface, and those coming from the 60 degree, they are refracted much more from the inferior edge and the posterior surface of the lens. So what they found was the maximum refracting angle from the rays refracted by the IOL was 85.7 degrees and the minimum RFA was 88.3 degree. So this difference of 2.6 degree in the extreme temporal field is what is responsible. So they have done some physics and they found what are the factors required to develop negative dysphotopsia. It has been classified into primary and secondary factors. primary small pupil, more distance behind the pupil of, they have calculated it to be 0.06 to 1.2 for acrylic and 0.06 to 0.62 for silicone. What happens is there is very little distance between the normal iris and the natural crystalline lens, because it is of about 4 to 4.5 millimeter. But once it is replaced by intraocular lens, which is less than 1 millimeter, the gap between the iris and the anterior surface of the lens increases. And this is the distance they have calculated to be 1.2 for acrylic and 0.62 for silicone. A sharp edge design, functional nasal retina that extends much more anterior to the shadow, and secondary factors are short axial length, high intraocular lens power, high index of refraction like 1.55, small IOL diameter, large angle alpha, nasal location of the pupil, transparent state of the peripheral nasal capsule, and non-inferior temporal orientation of the optic-haptic junction, which I'll explain subsequently. Masket said IOL position is responsible. So either it is IOL, basic problem is IOL, whether it is IOL material, high refractive index, IOL edge design, square edge, IOL size, which is of small diameter, or IOL power, which is high. Samuel Mascot's theory also implicates there is some CNS involvement, because the patient may have negative dysphotopsia, mostly bilaterally. Why this dark shadow occurs only temporally? Because light coming in nasally is tempered by the nose, eyebrow, and cheek. And second factor is that the nasal retina extends further anteriorly than the temporal retina. These are some of the pictures the patients have withdrawn. It is a sickle-shaped shadow. So it can take form of black edge, black crescent, blurred edge, or black corner. Incidence initially is high, 20%, but gradually it decreases after 6 months, and after 2 years it remains from 20% to just 2.4%. It is classified as transient dysphotopsia, which resolves in 2 weeks, temporary, which resolves in 6 to 12 months. It is the persistent variety which annoys the patient and perplexes the surgeon. So I'll repeat, it is associated with well-centered in the back PCIOLs. Does not happen with poorly centered IOLs, sulcus IOLs, or anterior chamber IOLs. It increases with bright light, and symptoms present early and usually resolved by 6 months to 2 years. And dilate the pupil, problem resolves. Constrict the pupil, problem worsens. Since no medical therapy seems to work, surgical management is tried. And what are the surgical management which are available to us? One is removing the nasal annulus of the anterior capsule by YAG laser. Second is placing shoulders of the haptics of 3-piece IOLs horizontally, in fact, inferotemporally and superinasally. Reverse optic capture, piggyback IOL, and then there are some innovations like anti-dysphotopic IOL and bag in the lens IOLs. So this is a very simple procedure where you can just YAG the nasal annulus of the anterior capsule. This goes to prove that in some of these cases, the shadow of the anterior capsule was responsible. Placing the IOL's haptic horizontally, how does it help is when the light comes and strike the optic haptic junction, through that the light bleeds into this shadow, and so this shadow disappears and the problem may resolve. Reverse optic capture, what you do is you tease the IOL of the anterior capsule with a blunt instrument. You bring optic in front of the anterior capsule. So what do you do it nasally, then temporally, and this reverse optic capture also helps in few percentage of the patients. Piggyback IOL is placed in some of these patients. How does it help is, it again decreases the distance between the iris and the lens which has been put, and the shadow is also removed. So this is, Masket has given anti-dysphotopic IOL. There is a bag in the lens by Mary Jo Tissignon from Belgium. Then there are designs by our own Indian innovators like Dr. Shri Ganesh and Dr. Prakhyat Roop. And when do you do IOL exchange? IOL exchange is the last resort where the symptoms do not resolve in 6 months. Then consider lens exchange. Now you have to replace the lens with a low refractive index. Material may not be acrylic. Edges are rounded, and optic diameter of the lens is large. Surface reflectivity is low, and the more power is moved to the anterior surface. But imagine if the patient already has these kind of lens, then what are you going to do? So this is a flow chart which has been prepared, that how you have to go about doing this, tackling these patients. But there are still some unanswered questions. Why does it occur only more in left eyes? Why is it greater in women? So there is a CNS connection which is not explained by any simple theory. So is cause IOL position the only cause? precise reasons why certain patients encounter negative dysphotopsia and others do not still remain a mystery. Reverse optic capture and piggyback IOL implantation in the sulcus are the most successful approaches for negative dysphotopsia. So the take-home message is surgeons need to know and treat that dysphotopsia is a real and legitimate problem. Don't fool the patients by saying all is well, but yes, you can counsel that all will be well in the near future. So dysphotopsias represent a failure of the current day cataract surgery and needs to be addressed by alteration of surgical methods, IOL designs, or both. If you are able to remove these haunting, unwanted images from the field of vision of these distressed souls, smile will return back to their countenance. Thank you everyone for your kind and patient hearing.
Thank you, sir. I think this is a topic very close to my heart, and I have an instruction course, 1 hour on that. You have done a better job comprising it in such a short time. You know, I call negative dysphotopsia as the curse of the perfectionism. It only happens when the surgery is perfect. I will not name a lens. It's a very expensive lens. I charged 2 lakh plus for one eye from a patient. He reported dysphotopsia. I explanted the lens. He said, don't give me the refund of money. I know you've done a good job because I've asked other people. Their surgery is all right. Explant the lens. I put another lens. He's worse. So again, my caution is when you're explanting a lens for dysphotopsia, exhaust all your options, because don't be surprised if the patient has dysphotopsia again, and then you have nothing to offer. So there is a concept of neuroplasticity,
yes,
and counseling. And once the patient understands there is nothing wrong with the surgery, and this is where us as a community should stand together. A person operated by Dr. Bhalla with negative dysphotopsia, if he comes to me, and if I find this as an opportunity to punch hole into him, this thing is never going to die. If I tell him that surgery is perfect, in fact, the very reason your surgery is perfect, that you are seeing dysphotopsia, and I could not have done a better job, the person will have more chances of accepting what Dr. Bhalla tells him, that okay, try and get used to it. But if I find fault with that surgery, don't forget, you will have such patients someday, and he will go to Dr. Bhalla.
Very rightly said. How I counsel my patients is, the mere reason why negative dysphotopsia is occurring is because your surgery is very good, your lens is very good. And he says, why it does not occur to all the patients? I say, because you are more intelligent and you have noticed it, others have not noticed. The patients are counseled well, they accept.
So I give an example कि चेहरे पे दाग गोरे चेहरे पे ज़्यादा दिखता है, perfect होता तो उस पे निशान दिखता है.
Thank you.
Sir, in your example, which was the eye? Was it left eye or right eye?
Most of the cases, Dr. Bhalla is right, 67%.
Your case,
This was a left eye.
left eye.
Yeah.
Left eye is more common.
The reason is they're saying that the nasal retina, the ora serrata in most of the anatomical cadaveric eyes
Extends more anteriorly
more anterior in left eye.
in the left eye. Same is true in females.
Yes.
So this is the reason they are giving, sir.
But all these things does not explain why the left eye is more involved. All these things does not explain why the left eye is more involved. I have also observed the left eye is more common.
The literature says anything between 62 to 75% left eye.
Left eye
patients.
is there.
Whatever surgery you do phaco, you do SICS, you do any surgery, with left eye is more common. So all these things does not explain why left eye is more common.
Maybe it's got to do something with the right hand dominance and the brain being more dominant to pick up these things. I don't know.
Thank you, sir.